Hi guys, Dr. Gillard. It's been a while since I've done one of these. I don't do many of these types of videos with my clients, but I got a really, really rare one here today. So rare that I can't find a single paper on it in PubMed. This is on my client. I'm a patient advocate for this client. I've talked to the Stanford neurosurgeon. He's never seen a case like this. So this is pretty... it's sad it's exciting for the patient because after 17 years, maybe we've figured out the causes of his radicular pain. So let's get into it. Super rare entrapment of the femoral nerve. And I have all different types of followers, right? This is pretty intense stuff. This is geared more for my radiology followers. I have quite a few of them. And some spine surgeons and such. So I apologize to the people. I'm probably going to go way over your head, but nevertheless, I'm pretty excited about this case. So femoral nerve anatomy, right? I'm an anatomist, so I got to do a little anatomy. And you're like, oh, no, I thought we were done with Dr. Gillard's anatomy. No, let's just look at the femoral nerve real quickly. So, of course, the femoral nerve is part of the lumbar plexus. In fact, it's the largest branch of the lumbar plexus. Here it is in yellow. 234, 2, 3, and 4, it comes off those roots. Specifically, it comes off the anterior rami, but even more specifically, it comes off the posterior division of the anterior rami. It gives off some branches to iliacus and pectineus, and that's about it. Its springs, a couple twigs, give rise to the lateral femorocutaneous nerve. Neuralgia paresthetica is another much more common clinical problem than what I'm going to show you today, and that wasn't involved in this case. Okay, here's a cartoon. It goes in the lateral part of the psoas muscle, so it normally is embedded a little bit, and then it pops out here about 4 centimeters above the inguinal ligament, and once it's out, it's out. It does not go in the iliacus. Here's the iliacus muscle right here. Here's the psoas major muscle. Psoas minor's been removed. Remember, psoas minor and the iliacus come together down here below the inguinal ligament to form the iliopsoas muscle, which is part of the floor of the femoral triangle. But again, the femoral nerve, it's not diving in or embedded in anybody. Kind of the point here. So it gives off, it supplies iliacus and pectineus, we said. It's got some sympathetic fiber and sensory fiber for the femoral artery and its branches, so it can control the size of the femoral artery. It enters the femoral triangle and splits into an anterior and posterior division. And I warned you at the beginning of this video that there are some cadaver pictures here, so those who are still with me, this is not going to bother them at all. So this is the femoral nerve. It's been dissected out of the psoas here. Some fibers are still left of the psoas, kind of a skinny psoas, but they dissected it out. Oh, you know what? I remember this picture. Actually, they didn't dissect it out. This is an anomalous psoas where the femoral nerve never went in the substance of the psoas. But you can see the branches. The iliacus muscle is all this right in here. This is all iliacus. And psoas is pretty skinny here. The iliacus is huge in this patient. This is all iliacus, and combined their iliopsoas. Inguinal ligament would be right in this region here. But there it is. The point of this picture is, notice there's like a little groove where the femoral nerve runs between iliacus and psoas major, and it certainly is not inside of iliacus. Now there is a iliomembrane that covers the iliacus, a little thin membrane that is over the top of femoral nerve, but that's been removed. But that's not important here. Here's just another one to show you. This one, they did dissect the femoral nerve out of the psoas muscle. It lives in the lateral part of the psoas muscle, as you'll see in the video I made. Yep, that's all I wanted to say on that. The femoral nerve is right there, and it's definitely not in iliacus. This is all iliacus right here. It's definitely on top of iliacus. Okay, some fun facts. So here's Standring says the main trunk of the femoral nerve is not subject to entrapment neuropathy. Oh, really? I beg to differ because I'm going to show you that's not true. Now, there's well-known retroperitoneal tumors and hemorrhage that can occur in people taking blood thinners that can compress it's still rare, but it can compress the femoral nerve. And pain and paresthesia from the femoral nerve usually is found on the anterior and medial part of the thigh. And maybe because of the saphenous branch, is the saphenous nerve we've seen in anatomy. Maybe it goes down into the medial leg. In fact, here is a patient who was on blood thinners and they had a hematoma. A vessel popped in the retroperitoneum and compressed the femoral nerve. He got terrible pain down in this region. So they drew the distribution of his pain and numbness and tingling and burning, and that was his. Some people have it down here, but it's pretty rare. Okay, here's the case study. So we got a 60-year-old male, and I'm the patient advocate again for this, so I have all this information. I got permission to release this. A 60-year-old male, chronic anterior thigh pain, medial leg pain, dorsum of the foot pain, which is described as a severe burning. It's set off by simply going up one stair will flare it up. Go up 3 stairs. It's like 1 stair per day, he said. And it'll flare him up. He tries to walk up 3 stairs, and he'll be in burning pain for 3 days and just miserable. Walking, he's good for, he can walk for about 4 blocks. He had a discectomy. They thought the problem was a small contained herniation back or at L5S1 on the left, and the complete disaster. It completely failed. And the surgeon actually numbed the nerve, filled it with lidocaine, and after the surgery, he was still in a lot of pain, and the surgeon thought he was crazy, according to the patient. He said, "It's impossible, I numbed the nerve." Well, maybe it wasn't the problem all along. Maybe we found the problem after 17 years. So here's some more data. And here's another clue that it wasn't the S1 nerve. An old Stanford EMG NCV was a non-Stanford, this was not done by Stanford, at L3, L4, and L5 radiculopathy, which how can a paracentral L5 herniation compress the L3 and L4 roots? And it can't really compress the L5 either. So that was weird. Nevertheless, they went for surgery, which they shouldn't have. Now, a recent Stanford EMG shows a chronic S1 radiculopathy, but there is scar tissue. A lot of scar tissue around the S1 root occurred after the surgery, so he's probably got 2 problems going on. Examination, left quad's really weak and thin upon measurement. Girth measurement was decreased by about 1.5 inches. The gastroc was decreased as well and really weak. Hip flexor testing was done at Stanford, and he said within 20 minutes of that test, horrible burning pain over his thigh again. And he's not letting anybody else touch him. No more examinations because that pain lasted for quite a long time. So the working diagnosis back then was, and currently is failed back surgical syndrome, failed discectomy, chronic S1 radiculopathy, confirmed by EMG. But here is the wild card. And their treatment was a spinal cord stimulator. He's got other health problems, so it would be kind of a dicey surgery for him, so he doesn't want to do it. So here's what we did, or what I did. I didn't used to be a big fan of MRI neurography, but it's getting really, really good. And so I did get the insurance to authorize a MRI neurography just to see if we're missing something in the pelvis. For those of you who don't know, it's, of course, done with a 3 Tesla tube, and they look at the nerve roots. You can follow the nerve roots down and see what happens, and you can look inside the nerve roots. So it's an MRI of the nerve, or the peripheral nerves, really, because AK is peripheral nerve imaging. So I keep saying nerve roots. I'm so used to saying nerve roots. Those are by the spine. But you can see the fascicles. You can't see the axons, but you can see the individual fascicles inside the nerve. So it's a crazy test. You have to be very, very experienced to read this thing. I have a good friend who's a radiologist for 35 years. Won't look at him. He can't. It's just too much. You have to be a neuroradiologist or maybe a musculoskeletal radiologist can handle this, but this is really hard to read these things. You have to be an expert anatomist. So, drum roll. Here's this guy. Some of you guys who don't know this stuff is not. You're gonna go, oh, doc, this is really boring. But for you radiologists, people who like this, you're gonna be very excited about this. And before you take off, right after I'm done showing you these two pictures, I made a video of me going over the actual MRI films. So I'll scroll up and down, and you can see and you can follow the nerve root. But for those of you who want to take off, let me show you real quick. This is an overhead view. Here is the left. The sides are reversed. This is the left iliac crest. This is the right iliac crest. This is the iliacus muscle. Oops, right here. Iliacus. This is the psoas. They're combined, so this is iliopsoas. Same thing over here. This, let's look over here. This is the right over here. This little white spot, that's the femoral nerve, and that's where it's supposed to be. It's inside this little groove between the iliacus component and the psoas component of the iliopsoas muscle. This is where the excitement is. That is actually inside the iliacus muscle. There's no question about that, and that's impossible, but yet there it is. And it goes, if you hang around and watch the video afterwards, it runs all the way through here. So that's pretty crazy. Now, let's think. If you try to muscle test him, his hip flexors, he has a wicked flare-up, lasts for days. What does the iliopsoas muscle do? Hip flexor. So you do hip flexion, it contracts this and squeezes and pinches the nerve. And so it's possible this could be a source, at least part of the source, of his radiculopathy. He would be so happy if he could walk upstairs again. So I've patient advocate. I've talked with the Stanford surgeon. Stanford surgeon is excited. He's never seen a case like this. Certainly never operated. Doesn't know anybody who has. So it's a first. So we'll see. The next test, what we're going to do is we're going to block this thing at the inguinal ligament and see what the nerve distribution is. We're going to do a nerve block. And normally if you inject lidocaine around this nerve, you're going to get numbness in your anterior thigh, maybe your medial thigh. I'm betting anything that when we block this patient's femoral nerve at the inguinal ligament, I'm betting it's going to go all the way down into the foot. I think it's an anomalous nerve, and that's what I believe. But we'll find out. We're going to test that theory, and I will report back. And if that's so, the patient is willing to try a surgery to release it from the iliacus, which Stanford will do, but no one's ever done it before. At least according to my research and the Stanford doc, we don't know anybody who's done this before. And a general surgeon would have to come in and pull the peritoneum over. Hopefully we won't have to crack the peritoneum and expose the iliacus. And he's going to have to dig that baby out of there and decompress it. And so we'll see. So we're just at the very first stages of that. There's another picture of it there. Just to show you, there's the other nerve is already out. It's out in that little groove. And this one's still deeply embedded in the iliac muscle. So very exciting to me. Sorry if it wasn't exciting for you, but I thought it was super exciting. I've never heard of anything like this. So stay tuned. You can see if you want to see me going over the actual video, I'm going to do that next. If not, thanks for hanging around and watching this. And stay tuned for the update. Give me a thumbs up if you like it. Subscribe so you can be notified when the next video comes out. It tells you the results of that block. Should be exciting. See you in the next video. Hi guys, let's take a little bit closer look at this. I presented those PowerPoint images. Those of you who really understand this stuff, I do have some radiologists who follow me, and for them and some high-level spine specialists might get a kick out of this. But let's actually show you where this entrapment is for real. And so to do that, we're going to go down to L4 here. right? So there's the L4 exiting nerve root. This is the left side. This is the right side. Remember, these images are reversed, and I got all the patient information because I'm trying to protect that. And let's follow this and see where we go. Now here, before we go anywhere, here's the psoas major. You can see it right here. Here's the iliacus. It'll become more prominent here in a minute, but this is all the iliacus muscle. All right, and let's follow this and see where L4 goes. Right, so step by step, here we go. So there it is. We're going to keep watching this white thing. This is going to turn and meet the others to form the femoral nerve. There it is there. There it is there. There. And it's okay. It's going to go inside psoas. It's supposed to go into psoas normally. It's designed for that. And so it's a little bit inside, just the lateral part of psoas there. Okay, but now look how the iliacus has come into view nicely. This kind of, I don't know what shape that is, half a circle maybe. Here's that little groove. Once it comes out of the psoas muscle, it's going to hang in this groove, which is where it's supposed to be. And so that's fine. So now it's coming out. Now it's in perfect position. So great. Everything looks great. But let's keep going down. We're going down cut by cut. This is, by the way, this is an overhead view. This is an axial. And each slice, we're going down lower and lower and lower toward the ground. And now it's starting to get a little funky here. It should be right here, and yet it's over here. It's starting to kind of bite into the muscle, which is a little strange, but this area is a little strange anyway. And so it's still a little strange, but I mean, here's the other one. So that looks a little funky too, but that's normal. There's the crack that it hangs out in. So it's not too crazy yet, but let's keep going down, and now it's crazy, right? It's definitely inside the iliac muscle. The other one is in that little crack that's right there, right? That's where it's supposed to be. It's not designed to be inside the iliac muscle. And we're getting close to iliopsoas, actually, right? I mean, technically, it looks like iliopsoas has formed, even though it's in the iliacus portion. All right, let's keep going down. Let's see where it goes. It's still inside there. Still inside. There it is there. Still in there. Still inside there. Still in. See, the other one's come out already. It's come out of that little crack. This guy is still completely buried in there. And that's the left femoral nerve. Still inside there. Still inside. And finally, it starts to pop out. Okay, so finally, there it is on the outside. So it's got a really long course through the iliacus portion of the iliopsoas. Let's see it again. Just keep watching it. And there's no paper. I can't find single paper. I've talked with the spine surgeon. I'm a patient advocate, so I got permission to talk with the spine surgeon. And he has said he's never seen anything like it. He's never operated. He doesn't know anybody who's operated on it. So this is a super, super rare thing. So it's exciting. This patient's been quite disabled for 15 some years. I can't do the math. What is the math? 10, that'd be, let's see, 13. Yeah, coming up on, 17 years or so. They've been severely disabled. They can't walk up a single step. If they do, they have a flare-up for 3 or 4 days. And the more steps, the longer the flare-up. And that would make sense, right? Because when you climb up a step, you're exercising your psoas muscle, and it's getting pinched inside there. So it makes sense. Plus, when they on examination, testing hip flexion, within 20 minutes, recreated burning pain over the thigh and a little bit down the leg as well, but mostly burning pain in the thigh. So people, I mean, I've been doing this a long time. I've never seen a patient with a S1 or L5 or even L4 problem have that kind of symptom. So maybe this is the answer. So we'll find out. So what's the next step? And what's the other problem with this? Well, the other problem is the symptoms, because we all know the femoral nerve normally supplies the anterior thigh and the medial thigh a little bit, and it's got a saphenous nerve. So rarely people an irritation of the femoral nerve can go down into the medial leg, but that doesn't happen that often. So this patient has pain on the lateral leg, top of the foot, the outside of the foot, the S1, so really the L4, L5, and S1 dermatome. So that doesn't make sense, does it? So here's the plan. The next step is to do a block of this nerve, and unfortunately we can't block it inside, we can't get it where it's entrapped here, because the intestines, this is inside the pelvic cavity. So that would be a huge procedure, right? We'd have to get it, this would be a major surgery. You'd have to pull the peritoneal cavity out of the way, hopefully, and then you could get at it. But that's, for a block, is ridiculous. So what we can do is we can do a nerve block at the inguinal ligament, and that's a pretty innocuous area. That's not going to cause much trouble. I mean, there's always risk for any type of procedure, but that's a pretty straightforward procedure. Numb that thing up and see, because when you numb a nerve, the sensory and the motor portions are knocked out. And so the sensory component of the nerve will display to the patient as a numbness over their leg. And then we'll get a marker and we'll map where this numbness is. And what we're hoping is it's going to be a very strange numbness. We're hoping that it's going to be over the dorsum of the foot, the lateral part of the foot, the medial part of the foot, the lateral and medial leg. That would be incredible. That would prove the theory that not only do they have the femoral nerve as anomalously coursing, but it's just anomalous in general, and it has a very strange distribution. So that's the plan. And if that is true, if it does map to the same distribution as the patient, as the patient's pain is, then we got to consider possibly doing this decompression or release procedure, where the same thing I said, a general surgeon would come in and try to pull the peritoneal cavity over enough, and then the neurosurgeon would come in and try to free it, try to kind of cut it out of its little coffin here and free up the course. And the trouble is it's a long course. It's from there all the way to there. So that's a lot of freeing up to do. So I worry about scar tissue, and we'll cross that bridge when we come to it. But that's the story. And again, I don't post many of my client videos like this, but I have permission, of course, to do this. And it's just one of those really, really rare ones that I think some of you you'll get a kick out of. All right, so I hope you enjoyed it. If you have comments or questions, leave them down below, and I'll try to get to those as soon as I can. And go ahead and subscribe if you haven't done that. Give it a thumbs up if you like these videos. And if you're not subscribed, you won't know when the next step, because I'm going to do an update after the injection to see what the results of. I feel like a kid on Christmas waiting to open my package. I'm really excited to see if I'm betting that this distribution is going to be very anomalous as well, but we'll see. All right, hope you enjoyed it. I'll see you in the next video.